Hello, I'm Dr. John Kruse, and welcome to today's question and answer hour. So I'll be here available to talk for about an hour. I'm answering questions on the video I released this past week on other ADHD topics in general, and even more broadly on mental health or physical health or neurologic health, as I see the first question. A reminder that what I say here is for informational purposes only. It's not intended to be specific treatment recommendations. Hopefully, you can bring this information back to your treatment team if there is one. And two other things before I launch into a summary of the video. One is that if you want a forum for a greater discussion of some of these topics, I have a subreddit, and the link to that is floating somewhere around. And on this Friday at 11 o'clock West Coast, 11 in the morning, West Coast time, I will be one of the speakers on Medium Day. So Medium is a writing platform where I've contributed more than 300 articles over the last 5, 6 years on largely ADHD, mental health, but other topics as well. So I will be talking about writing for an ADHD world at 11 o'clock. Registration for that is free. So the video that was released this past week was called AI-induced psychosis. So AI has only been around, it's not even 3 years yet, it's been commercially available, and AI can do tremendous data matching, sorting through huge realms of information much quicker and more efficiently than humans can. It's already improved diagnostic accuracy of predicting who will be suicidal after a psychiatric hospital admission, for example. It may also have positive roles in helping isolated people be less lonely. But there have been reports for more than a year now of AI and supported and abetted suicides. That's gotten a fair amount of media attention. AI-induced psychosis has gotten less information. So the suicides have been largely young people, mostly teenagers, who were explicitly seeking out AI for companionship or for confiding information in. They went to AI with suicidal thoughts and feelings. And in most cases, initially it behaved properly, telling them to contact these support numbers or to share this information with humans in their life. But the AI was rather easily subverted, particularly by saying, I'm just interested in this topic as a research purpose. And in numerous instances, AI has given explicit information to kids on how to kill themselves, some of who have, and actually in other cases encouraged them by sort of praising their individuality and their courage and behaving in ways that others wouldn't dare do, and abetted in keeping information hidden from important adults in their lives. So a completely, not maybe not completely different, but AI-induced psychosis is a different phenomena. This is a much broader age group of individuals seem to be affected. The Most of these people are going to AI just for information seeking purposes, which is commonest used for LLM AI use in the general population. So they're not going to seek it out as a confidant or companionship. Excuse me. And then these individuals get eventually engaged in very arcane, detailed discussions of technological topics, particularly physics and math, which these individuals had no previous interest or expertise in. And they get engaged in hour-long, days-long conversations. The individuals eventually become so focused on their AI interest that they deprive themselves of sleep, they neglect their social contacts, they neglect their work tasks. And then there's a segue into a more floridly, classically delusional state where these people, in conjunction with AI, feel that they are making wonderful contributions to science or humanities or to AI itself, and that their contributions are being ignored, neglected, devalued, they're being cheated out of money that they are due for these advancements, and then more florid delusional symptoms of believing they're being spied on, believing they're being surveilled, that their lines are tapped, their phones are being listened into, that people are out to hurt them or harm them or steal their secrets from their brain. And so it's a full blown psychotic state, which can continue for weeks or months. There have been more than 100 documented cases of this, and at least 10 deaths are being investigated connected to this. At least a third of those 100 people required hospitalization. Um, so, in my estimation of this, it most closely resembles something called folie à deux, which is a psychotic state shared by two different people. Usually, a dominant individual inflicts their psychoses on a more passive, highly enmeshed, highly connected, and usually the pair are fairly isolated from other individuals. And it's a rare enough condition that um, there's not extensive study on it, mostly just case reports, and separation of the people seems to be important. So, one particularly of time in the US where both the president, the executive branch, and the congressional branch have forsworn any regulation whatsoever over AI and have even proposed legislation that would ban any states or other jurisdictions from putting any jurisdictions from putting restrictions on AI. To me, this is a field that clearly needs more monitoring and guidance. So that's all. I'm happy to answer questions about that. So, getting over to the posted questions, Jack asks, what's the difference between a psychiatrist and a neurologist, and in particular, the way they treat ADHD? That's interesting because I was thinking of this morning. So, in the United States, where I trained, I'll sort of start with the training. So, both a psychiatrist and a neurologist have gone to medical school. Then with psychiatry, there's a 4-year psychiatry residency program where just the first half, 6 months, are general medicine internship. And of that, at least one of those months is a neurology rotation. Neurologists go through a 4-year neurology um, residency program. I don't believe that there's any requirement for any psychiatry in that. So initially, psychiatry and neurology were one big happy, maybe not so happy field in the days of Sigmund Freud, and they've diverged since then. And it's a little flippant, but it's the sort of storyline is once we know the precise etiology, origin, cause of a condition, it becomes a neurologic problem rather than a psychiatric problem. And if we're still vague and uncertain of what the problem, so many of the movement disorders, myasthenia gravis, muscular dystrophies, are firmly in the realm of neurology. Something like Alzheimer's, dementia is moving in that direction, and the conditions we can conceive of as more mental health conditions are generally psychiatric. But if they have a precise physical origin, and something like Huntington's psychosis connected to Huntington's disease is a neurologic condition. So a couple other things. There are many more, about 4 times more psychiatrists than there are neurologists. And although Oliver Sacks, who wrote Awakenings, about people awakening from encephalitis lethargica, which starred Robin Williams in the movie, or he also wrote The Man Who Mistook His Wife for a Hat and other stories. His books focused on interesting behavioral quirks caused by problems in our central nervous system wiring. He is by no means at all a typical neurologist. So, again, most neurologists are focused much more on definitive non behavioral conditions, so motor movement conditions that we know the precise pathways are. And during my medical school training, I worked extensively with a neurologist who was sort of an oddball because he started a brain trauma clinic. He was interested in behavioral aspects and psychiatric aspects. And pretty much, even though he was respected for his intelligence, particularly the residents in the neurology program sort of scored him as this oddball. Who cares about these weird things? We don't really know what's causing them. And again, despite the Oliver Sacks counter model, lots of neurologists are not particularly interested at all in behavior. So, in terms of treating ADHD, many more um, individuals with ADHD wind up being treated by psychiatrists than by neurologists. If you look at what's going on in the US, less than a quarter of people with ADHD, adults, are being treated by psychiatrists. The biggest treatment group is actually nurse practitioners, and there are more general practitioners treating people with ADHD than there are psychiatrists. So psychiatrists are a minority. In terms of the differences among children, it's both child psychiatrists, general pediatricians, and pediatric neurologists who focus on ADHD. And again, I think there's a fair generalization that the psychiatrists are more interested in behavior and impact on their whole life, and the neurologists tend to be more focused on just getting the right medication and adjusting the medication to titrate the symptoms. That's what I can say. There's certainly exceptions in both fields, but I'll stop there. So, good question. I hope, if I didn't answer it well, follow up, please. So, Dylan Konatzer asks, does duloxetine worsen anxiety before it helps it? He's heard that SRI, I'm assuming gender there, sorry. They've assumed SSRIs can do this. So duloxetine, which is an SNRI, so it's norepinephrine and serotonin reuptake, absolutely can increase anxiety in the first several days of taking it, as can an SSRIs. And that seems to happen in about a quarter of people, depending on what dose you start at. And my own clinical experience is that's less common among people with ADHD to feel initial anxiety, but certainly possible. And somewhere between 2 to 4 weeks on the medication, substantial anti-anxiety benefit, just as the timing of antidepressant actions kick in. So yes, someone should be forewarned that initially it could worsen anxiety. And the follow-up question from Dylan is, duloxetine a good choice for someone who has ADHD comorbid with PTSD? So my answer is, and this is a little flippant, is duloxetine a good choice? It's a good choice if it works for you. I don't know ahead of time, and nobody knows now whether it will be good for you. What I would say is it is certainly a reasonable choice for many individuals with ADHD and comorbid PTSD because it has some potential for addressing both sets of symptoms. Dennis, asks, are there ways of protecting the health of the hippocampus? So the hippocampus is intrinsically involved with memory. It's probably involved with lots of other aspects of the brain. It is one of so my recipes for avoiding damage to the hippocampus, it is one of the parts of the brain which has some susceptibility to alcohol. And the more we look at alcohol, the more we see that, yes, probably young brains can get away with some of it, but there are cumulative effects. So I would say staying away from alcohol is probably good. At least in rats, there's good evidence that giving them access to a running wheel. So I should back up a little bit. Among mammals and including humans, the hippocampus is one of the few areas that seems robustly capable throughout adulthood in making new nerve cells, which make it special. And at least in rats, giving them access to a running wheel, so physical activity seems to lead to increase in brain-derived neurotrophic factor, BDNF, and that promotes new nerve cell growth in the hippocampus. So whether that's running specific or whether it's any rhythmic aerobic activity, so whether swimming, biking would work as well, is not clear, or whether it even has to be rhythmic, maybe judo or any other workout. We don't know which aspects of physical activity, but probably running, brisk walking are accessible to many people and good ways to start. And the other thing that's been shown to, at least in a wide range of laboratory situations, to promote new nerve cell growth in the hippocampus are many of our antidepressants, particularly SSRI antidepressants. So, and there is fairly good evidence that the longer someone has spent time in depression or anxiety, the greater the atrophy or shrinkage of their hippocampus. There's probably some common factor that's predisposing to shrinkage of the hippocampus and depression itself, but there does seem to be a correlation with the longer the time the brain spent in depression. And yet, given that pre existing connection, the longer someone gets free of their depression and the longer they've been on antidepressants, the less that shrinkage in the hippocampus is. So, again, I'm not saying everyone should just get on SSRIs to save their hippocampus, um, but there do seem to be medications with some protective effects. So, thanks, Max, is providing the link for the Medium Day Zoom conference. So CJ Betts asks, have I got anything to say about pharmacogenetic testing for ADHD drug metabolism? Um, Max is suggesting I keep the microphone even closer. So yes, I have a whole video on that. There's two two different ones on testing. One is about urine testing, drug testing, and one is about pharmacogenetic test, genomic testing. So I am not at all a big fan of it for a couple of reasons. One is ADHD is among the few conditions in psychiatry, maybe in general medicine, where within a dose or two of most medications, you know whether they're working or not. So take 5 milligrams of Adderall, you feel some benefit or not. If you're not having side effects and there's some indication it's working, it makes sense to go higher the next day. So you're not saving any time, or it's not creating more efficiency usually to get genomic testing, which last time I've ordered it through commercial companies, and this may well be quicker now, it was at least a 2-week wait for results. Secondly, most of what they focus on are um, P450 enzymes, so enzymes in the liver that break down and degrade different drugs. And what they can tell you is if you have this variant of the gene, you're likely to chew up the drug quickly, or you're likely to not chew up the drug really quickly, and the lots are likely to last around and levels are likely to be higher. All that tells you in and of itself is whether a standard dose will give you a higher blood level or a lower blood level. That does not tell you at all that whether that's going to work for you or whether that's going to be dangerous for you. It tells you that if you're a rapid metabolizer, you will probably need a higher dose to get an effect. You're probably less likely to run into side effects. But it does not tell you whether it's effective or not. Thirdly, very few of the tests include epigenetic information. So it's one thing to tell which form of a gene you have in terms of metabolic activity. If you have a really fast metabolizing gene, that's interesting to know. But say you have a really rapid metabolizing gene, but your body isn't expressing much of it because for whatever reason it's had methyl groups or other things stuck on it. So it's relatively inactivated by epigenetics. So again, telling which form of the gene you have without knowing how much of it's being expressed or made is not particularly useful information. So there may be very rare conditions where they're useful information, but I'd say almost all the time I've seen them, at the very best, what they're doing is just confirming what someone's already seen in figured out clinically. Yes, they need high doses of these drugs. No, they respond really well to low doses. So, so thanks, Max, for bringing up this question. I was going to go into it, and I didn't know if I was going too long. So Max is asking: is the word "induced" used in the sense that it only brought on the psychosis, but it's not the cause of it? Is it that the individual was prone to psychosis and the event was just the trigger? I've written, particularly in response to writing about AI-induced psychosis, I got a fair amount of pushback from, I will say, fans of AI and people who know much more about AI than I do. And they criticized the term AI-induced psychosis on two grounds. One, they felt that it was blaming AI for the condition, and their contention was that most of these individuals are particularly susceptible for some reason or another. But then, two, they also brought up that the whole AI induced psychosis was pejorative in blaming the victim. Um, so, one, I would back up and say, what else do we have as an induced psychosis? We have marijuana induced psychosis, we have Adderall, amphetamine induced psychoses. Those are labels we currently use and are established. That's meaning the drug, the substance in this case, is having a critical role in creating a situation. It's not saying it's the only cause. I mean, everything is with human behavior is always nature and nurture. It's always a brain interacting with its environment, but it's saying that there is something about this particular aspect of the environment. So we don't talk about aspirin-induced psychosis or milk-induced psychosis, or I mean, most substances in our environment are not triggering individuals to have psychotic reactions. So, although I sort of accepted some of the criticisms initially, I think the longer I've thought about it, the AI induced seems appropriate because, I mean, yes, I guess some individuals can be more prone than others, probably. And with the folie à deux literature, the that situation, again, there are about 1% of the population is schizophrenic. Many people who are in psychotic states for a large part of their lives are in close contact with caregivers, family members, and caregivers, family members do not routinely develop or adopt the psychoses of a schizophrenic person. So again, in folie à deux, it's usually a dyad. There are other scenarios, but it's usually two people in a tightly enmeshed, connected situation. And um, one individual is dominant, the other is passive. It's the dominant individual who's delusional to begin with, who passes on their delusional thoughts. And there seems to be some association between language difference difficulties, cognitive difficulties. Some people have suggested neurodivergent difficulties or challenges among the more passive individual. I've I checked, and everything I can find that's written about folie à deux are case reports or trying to summarize case reports. There's no quantitative assessment of who actually winds up in such situations. But again, the anecdotal evidence so far with AI-induced psychosis is that the vast majority of these individuals were not having pre-existing psychiatric conditions. Again, they were not seeking out AI for companionship. The very enmeshment that they fell into was, I would argue, more globally a human phenomena. I mean, we all, and AI, ChatGPT particularly, has pulled back on how sycophantic its um, ChatGPT, I think 4 and 5 were initially programmed to be. So one is that there are a lot. This is a huge field in terms of potential market and billions of dollars already churned into it. The success among these different large language module chatbots is not going to be determined by which is the most precise or accurate at summarizing information. Some of it is going to be determined by what people enjoy and like using. And if you have a chatbot that praises you, that recognizes your individuality, that tells you how smart and wonderful you are, that's something most humans are going to have at least some susceptibility to. We are social animals. We are programmed to want to be recognized and want to be appreciated because if you were left alone and neglected by your tribe, you would die. And humans did not exist as solo um, individuals out on the savannah. Even if they existed, they didn't procreate and spread their genes. Um, so I think we need to be careful. Again, the evidence so far is not that the majority of people. So again, this is different from AI-induced, AI-abetted suicide, where those individuals very clearly were dealing with some significant mental health stressors, depression, PTSD, suicidal feelings when they sought out AI. That's not the situation here with AI-induced psychosis, at least as far as we can tell. So I should give a shout out to the Human Line Project. That's a volunteer organization started by a guy up in Quebec after a family member, an adult family member, developed an AI-induced psychosis. So he is trying to set up support groups, trying to gather information, trying to collaborate with mental health professionals so we learn more about this, and trying to lobby the um, AI community so that there can be some safeguards, guidelines put on these chat boxes, bots. The other thing I should say there that's to me particularly alarming or scary is even the programmers who have worked on AI will tell you quite freely, we do not know or understand the algorithms by which Claude or ChatGPT, or I'm not remembering any of the other names, come up with their specific answers to any question. This algorithm is a black box, it's opaque to us. So if that part of the process is opaque, it means any safeguards, any guidelines, any restrictions they put in, you don't have much certainty as to how well they're going to work. I mean, you can, I'm being overly simplistic here. You can say, don't do anything dangerous that leads to someone harming themselves. And you don't know how AI is interpreting that guideline. So again, we need to be more careful. We need to be putting in safeguards, but even putting in safeguards, we don't know how well they're going to work. So thanks, Max. So Max brought up the link. Um, sorry, I'm jumping around. Um, sorry, somehow I've jumped through a whole lot. So, sorry. James Alexander asks, some online claim eating snacks throughout the day benefits ADHD patients by keeping their blood sugar steady throughout the day. Are there any dietary routines like eating breakfast first in the morning or snacking that have benefited your ADHD patients? Are there any dietary practices or food choices you personally practice to optimize your cognitive performance throughout the day? So, good question. And diet nutrition is one of the most bandied about topics on the internet. Clearly, there is some effect. If you eat nothing, you're going to be dead. If you eat too much of lots of things, you're going to be dead. So I'm not saying there's no effect, but one of my videos goes into great length as to why lots of things that we're claiming are changing neurotransmitter levels or affecting us profoundly are probably at most having mild effects. So one thing is blood sugar levels. If you are not diabetic, then the very job of your pancreas is to regulate insulin levels so you're not skyrocketing to high levels. It's to keep blood sugar within a normal range. So energy reserves are there for your brain and muscles as you need them. That being said, the things that I've seen most, so taking multiple snacks during the day, I'm not aware of any research showing that that helps regulate blood sugar level in someone with ADHD or even without. And I'm not aware of any study. They might be there. I just haven't run across them showing that snacking throughout the day is actually beneficial in terms of ADHD performance. One of the things I've noticed is that, and it may be tied to either lack or decreased proprioceptive, interoceptive capabilities, that it's fairly common for ADHD patients, people to say, "Oh my God, yesterday it was 3 o'clock before I realized I hadn't eaten all day." Now, some people don't eat for fasting. Some people don't eat because they have anorexia or some other eating disorder, but just forgetting to eat is not that common among most individuals, maybe at the time of severe crisis. And so, one of my standard approaches is in terms of scheduling, and scheduling is one of the biggest, most effective tools for ADHD, is schedule the big four before you schedule anything else. Big four are sleep, eating, some movement or exercise, and some rest or relaxation before your activities. In the eating, you should schedule your meals. You should have reminders. I had lots of people, particularly in the tech field, who did fairly well pre-COVID when there was food on hand at their tech company, and crowds of fellow programmers or others went to lunch at close to the same time, or at least in their working area. So there were visual and social reminders to reinforce it. And then they were working from home and with no structure, no reinforcement, no readily available food. So scheduling meals, absolutely, I strongly recommend. Um, Again, it might turn out that some regimen of fasting, some regimen of snacking turns out to be optimal, but I don't think we have any substantial data on it. So, in terms of what patients have reported over the years, I do think having at least some amount of protein with breakfast seems to be beneficial to many people. So, not having just your waffles or just your toast or just a cup of coffee. And the second thing with breakfast is having some bias towards complex carbohydrates or things with a low glycemic index that aren't just flooding you immediately with sugar and then having a sugar crash afterwards, but having more slow, sustained release of glucose into the body seem to be helpful. I've seen and heard less consistently whether there's anything special about lunch or dinner that people need to attend to. Um, and again, jumping back to a previous question, I'd say the more we look at it, alcohol's not good for your brain. Um, there's a lot of research that's been done on sugar and ADHD, and most of the research suggests that the acute effects of that sugar does not have acute effects on exacerbating ADHD symptoms, but there may be detrimental effects to the brain from long-term overdosing on sugar. So that's what I would say there. So Max says, how does one handle a violent situation where one side tries to escalate, but the other continuously ramps up the violence? Doesn't de escalation require both sides to make an effort towards it? So I am not a trained expert on conflict management. I mean, that's certainly part of some small part of psychiatric training. There are specialized programs and training groups that focus on this more extensively. I mean, clearly, though, if both sides went into it saying, "Hey, I'm into de-escalation. Hey, I'm into de-escalation. Let's de-escalate together. We don't have a crisis." So again, there's a whole field designed with the awareness that in such crises, at least one party isn't initially predisposed towards de-escalating. So part of it is being patient, part of it is being non-provocative, Part of it is creating a space so that the individual who's trying to escalate, so it's made clear to them that we understand what your interests are, we understand what your drives are, and there may be ways to achieve that without meeting force with force or escalating force. Some of this, although there's certainly parallels to what happens at a one-on-one interpersonal level and what happens at a country to country level, there are also additional dynamics and factors and forces at play. So, while in general I am in favor of not meeting anger with anger, do I also think Ukrainians are completely justified in resisting a Russian invasion that's trying to take away their attempts at being a democracy and attempts at determining their own national course? Yes, I do think that their defense is justifiable. Um, so that's that's where I'll. I mean, maybe we can come back to that or circle back to that, but that's where I would start out. So again, part of it is patience. Patience goes a long way in the long run. So James Alexander asks, why do I think most people develop significant tolerance to caffeine and nicotine, and tolerance is commonly observed in users of illegal stimulants like cocaine and methamphetamine, but much less common among ADHD patients? What could be the possible pharmacologic mechanisms behind these differences? One, I mean, it's easier to um, hypothesize about. I'll start with pharmacologic doses of ADHD stimulants versus non-pharmacologic, the dosages that are being abused or the substances that are stimulant substances that are being illicitly used and abused. One is that either because of the specific drug itself or because it's being binged, used at a higher level, there's greater flooding of dopamine and or norepinephrine synapses. So a low and steady level may be much less likely to create tolerance than overflooding it, whether people taking their coffee fix or their cigarette fix or their nicotine and caffeine in other ways are more likely creating a binge picture or overflooding of certain receptors than a slow and steady approach. There, I'd say it's harder to know or predict. There, it might just be more the very um, there it might have to do with more repetition of tiny dosage throughout the day, maybe more strong recipe for tolerance than taking one pill, which is gradually releasing, or even a 2 or 3 times a day dosing. So I think the pattern of dosing, as well as the rate of change of chemicals at the synaptic junction, I think are the two big factors there. But I don't have more precise mechanistic answers. Nick Lewis says, hello, hello. Another question about Cymbalta. Don't apologize. That's fine. Nick is on 120 milligrams and found that twice a day dosing is much better for me in terms of reducing my OCD symptoms and also better in terms of tolerance. Would you say once a day dosing would be more likely to achieve an optimal blood level to reduce ADHD symptoms? Um, so possibly. So possibly taking it all in the morning results in, so again, drugs like duloxetine are having some immediate direct effects on serotonin and norepinephrine reuptake. Those effects happen within minutes of taking the dose, and the strength of that effect does track when you're taking it. So is low just before you take it. It rises abruptly within an hour or two of taking the drug. It's at some sustained high level for several hours after with duloxetine, and then it's declining. The indirect effects, and that probably involves for antidepressant, anti-pain medication, anti well, probably pain as well, but also anti-anxiety effects are indirect effects, which probably involve messing with serotonin and norepinephrine, serving as a signal to the brain saying, hey, brain, make new proteins, send those proteins to far off parts of the nerve cell, which again, in some cases can be centimeters away and can take days to deliver, probably make new brain cells, particularly including in the hippocampus. Those are all slow, indirect processes that are not at all dependent on having a steady state level in the blood or related to the level of the drug in the blood at any given moment. So theoretically, yes, I would think if you took all your duloxetine in the morning and none at nighttime, you would probably have more detectable improvement in ADHD during the day. Whether there is also some indirect long-term benefit for ADHD is not clear. To my knowledge, it hasn't been studied with duloxetine. With Strattera, atomoxetine, a norepinephrine reuptake acting drug, there's both some immediate benefit, but there does seem to be some precortical indirect effects tied to glutamate and other systems that do contribute to its anti-ADD effects. So you're certainly not going to eliminate ADD effects taking it twice a day. And it may be for your brain, or it might be even in general, that the twice a day dosing is a great regimen for OCD. I mean, the other thing that's been studied, and it's studied more specifically, several studies with venlafaxine Effexor, which is another SNRI, although it's considerably weaker on norepinephrine. And this is primarily in studies for depression and I think anxiety. What they observed was once a day dosing tended to work better than multiple times a day, simply because people missed more doses multiple times a day. And particularly in an ADD population, I mean, if you have a good pill box or a good system and you're not missing dosages, great. But with ADHD, you are more prone to missing doses. And if you have twice a day dosing, the more times a day you dose, the more likely you are to miss some doses. So, which then might decrease efficacy. So that's my answer there. So, Max, thanks for providing the link on ADHD testing and on DNA testing for ADHD. So James Alexander asks, how do you distinguish ADHD from schizophrenia in patients whose ADHD causes them to have the disorganized speech, frequent derailment, incoherence, and grossly disorganized or catatonic behavior that DSM lists as characteristic of schizophrenia? I mean, one is there are almost certainly people using large language model AI programs, probably at Apple and Google and maybe elsewhere, to differentiate how these speech patterns at a neurolinguistic level of schizophrenia differ from ADHD. I don't know. I haven't seen that result, and I don't know that it's been published, but I'm sure there's work on that, and I'm sure there are differences at that language level in terms of disorganization. But I'd say that primarily with either ADHD or schizophrenia, you're not just focusing on how disorganized their language is, you're looking at other things they're doing. And again, with schizophrenia, usually there are what are called first class psychotic symptoms of delusions, of hallucinations, of being out of touch with reality, which are not classically there with ADHD. With ADHD, you're usually seeing other signs of inattention, other signs of distractibility, other signs of poor time management. Um, so So my overarching answer there is that, again, while there may well be discernible differences uh, in those speech patterns themselves, it's primarily what else or what is the context of speech patterns are occurring in that differentiate ADHD from schizophrenia. And thanks, Max, for providing the link to the Human Mind Project. So if you yourself are dealing with this, or you are aware of someone who is dealing with paranoia, psychosis induced by ADHD chatbots, that's a good resource. Dylan asks, how do I feel about using duloxetine for OCD? Is it a potential alternative to an SSRI? If so, what dosage is typically needed for this purpose? So, far and away, the most research on OCD and the only FDA approved drugs are SSRIs. Clomipramine, which is a tricyclic structurally but functionally is an SSRI, is also used. And a few clarifying points. One, compared to antidepressant dosages, OCD tends to need higher dosages and longer periods of time for treatment, so often 10 to 16 weeks to see strong effects. And two, measures of success are markedly weaker for OCD. So with depression, not that we always get there, but it's a reasonable goal to have complete remission of depression, to get someone out of a depressive state. A good response to OCD is a 20 or 30% reduction in OCD symptoms. It's very seldom eradication or complete suppression of OCD symptoms. Um, so, secondly, because duloxetine has good SSRI action, it's a logical potential option. And there is conflicting data on whether adding in that norepinephrine reuptake helps with OCD. So there are case reports where an SNRI is more effective than an SSRI. And there are also case reports in the opposite direction where the norepinephrine reuptake. Um, so I've seen people switch from an SSRI to an SNRI and develop OCD behaviors like um, I'm thinking more of repetitive body behaviors like chewing fingernails that they hadn't been doing before. So it I don't know that we have good predictors as to why, but it can go either direction, making OCD worse, or it can help make OCD better. So Nick Lewis asks, what are my thoughts on Focalin and how often to use it in my clinical practice? So among methylphenidate products, so I'll back up further. I see what the data very consistently indicate, and that is among the two stimulants and amphetamine-based products consistently help a greater percentage of people and reduce ADHD symptoms to a greater extent than methylphenidate products. That's what I see. Um, and I also see amphetamine products do have a higher likelihood of some of the really rare bad side effects. So I don't blithely prescribe them to everyone, but I certainly right now, particularly since I've shrunk my practice over the last few years to do more writing and YouTubing stuff, I have many more people on amphetamine products than on methylphenidate, and I probably have as many people on Cymbalta, Wellbutrin, guanfacine, and other things as I do on methylphenidate. So I'm not particularly big on methylphenidate overall, but within methylphenidate, Concerta, particularly when it was only available as a brand name product, I had just substantially far more people saying this works consistently, this has a good profile in terms of time of day of action. Um, I've certainly had a few people who Focalin worked very well with that for them, and they were happy to continue it. I've had people on Ritalin long acting. I've had people on Daytrana patches. I've had people on a number of different variations, but my clinical impression has been that there's more than a dozen newer products which try to adjust the ratio of left and right-handed enantiomers of methylphenidate, or try to juggle how much is being released at one point of time or another. I think Journey, delivering the night before, is a substantial outlier in a good way. It is doing something that none of the others do. But I'd say certainly there may be individuals who perform much better with one of those other options than with the others. But for most people, there's not much of a difference among them. They're making minor alterations that just don't have much clinical difference. So Focalin works for you, great. Um, if you haven't tried it yet, I would generally steer people toward, in my practice, Concerta first. But if you've tried Concerta and you felt that Focalin's likely to work for you better, it's reasonable to try. So, moving on to James Alexander asks, have I ever met anyone with the DSM-5's core autism symptom of persistent deficits in social communication and social interaction across multiple contexts, but not the other core autism systems of restricted repetitive patterns of behavior, interests, or activities? If you had a patient who presented this way and showed no other psychiatric symptoms, how would you diagnose them? Um, No is the simple answer. So again, I've not specialized in autism. Again, given there's an overlap between ADHD and autism, I've certainly seen and worked with a number of people clinically and in my personal social life who are on the spectrum. And I have not seen people with the social deficits who didn't also have restricted repetitive patterns of behavior and interests and activities. Now, I mean, did the partly the two seem to go together. If someone's not fitting in socially, then it increases the likelihood that whatever they are doing with their time by the society standards will be considered a little odd, a little narrow, a little. That doesn't mean they necessarily have to be repetitive. So there may be reasons for the overlap, but I do think that and I think the statistical data looking at symptoms does suggest there is a real association between the likelihood of having these two sets of symptoms. So Jack asks, can you give examples of CBT exercises I can do on my own? CBT for ADHD. One is what I would strongly say is there are many. So CBT itself, when you're using it for depression, for anxiety, is there are numerous handbooks, there are numerous self-taught manuals. It's well established. People can learn it themselves, teach themselves, do it practically. I have a video on panic attacks where I go through the CBT approach for panic. We know it's tremendously powerful and helpful. However, the core of CBT practice is one, detailed observations and keeping records of what seems to trigger or what promotes certain behaviors, which is hard for individuals with ADHD. It also requires lots of boring repetition of new alternative behaviors, which is also a hard call for people with ADHD. So I have worked with lots of extremely bright, extremely motivated individuals with ADHD who point to their bookshelf of 6 or 7 workbooks for ADHD, CBT for ADHD, and say, yeah, there are some good ideas in there. And I paged through them and, oh, I tried that approach a day or two and then I gave up on it or got distracted, went to something else. So CBT for ADHD is hard to do by yourself. So a strong recommendation is find a group or find an individual practitioner who can help with that. Um, I mean, I think scheduling, so I have a whole video on scheduling, is a core component of CBT approaches for ADHD. I mean, I think there's simple other tools like extending reaction times. I think much of the Pomodoro method for focusing on a task for a certain amount of time is essentially a CBT protocol. Um, I think I'll leave it at that. Max has included the video for CBT for ADHD there. Um, I'm certainly open to follow up questions or trying to expound on that if that's not helpful. So, Nick says this might be a controversial question. That's one of the best kinds. But what do I think about the notion that people with autism are more prone to violent behavior? Um, do I think that having lower levels of emotional intelligence is correlated to violent tendencies? So, part of why I mean, this is controversial because when violence happens, there are people quick to blame before they even have the facts of what's going on, as we have seen with the Charlie Kirk assassination. Um, Clearly, the majority of horrible, violent crimes in America, at least, are not being conducted by people who had a diagnosable mental health condition, although both being the victims of violence and perpetrating violence is slightly more common among people, for example, with schizophrenia than in the general population. But again, the majority of people committing violence aren't schizophrenic. With, with autism itself, I am just less familiar with the actual data or research that's being done. I think to me, there seems to be a logic that if someone's less aware of what or why social norms exist. And again, that's closer to the core of social obliviousness in autism than being anxious or worried about what others think about you. That's more social anxiety. To me, it is a reasonable hypothesis that that would make someone potentially more prone to violent behavior. Um, I've certainly lived near severely autistic individuals who most people would describe a lot of their daily behavior was violent in terms of acting out physical tendencies to destroy objects in their environment. Not necessarily people directed, but then not much awareness of when people were in the way or people were part of that picture. So, and do I think that having lower levels of emotional intelligence is correlated to violent tendencies? I mean, my guess is it's correlated both ways. So I think when we're getting into emotional intelligence, that's different than emotional awareness or not. So, for example, some of the psychopaths, so I would say someone like Vladimir Putin probably has above average emotional intelligence. He's been effective at knowing how to manipulate people, and and Benjamin Netanyahu would certainly fit in this category too. Both of them are clearly have relied on violence to satisfy and protect their own personal interests. And they've conducted in their respective countries more violence than their at least three predecessors ever did. So again, emotional intelligence, I think there's probably a biphasic connection with violent tendencies. Max says he has a hard time believing that we're more disinformed now than in the Middle Ages or Germany in the 1940s. I think the issue isn't as much internet media AI themselves as their usages. Yeah, it's hard to separate out there And one is internet meme is affecting being people exposed to many more people than even a widely read newspaper or a well-attended lecture in the let's go back to the 1920s. So I'd say that the internet does allow more pervasive misinformation, disinformation. I'd say particularly in the post-COVID era where we've taken away protections against misinformation, disinformation, a much higher proportion is likely to be false. I mean, was there yellow journalism in the Hertz and other certainly newspaper chains previously? Yes. Um, but I'd say so. I will date my so I can remember political discussions in the 1980s and the Reagan era, and by and large, not every example, not every there was agreement as to what the facts were, and there was just a different disagreement in terms of philosophy as to whether should the government be involved in focusing on reducing unemployment, should the government be involved in trying to um, shrink disparities in income or access to education or X, Y, or Z. That is radically different than what is occurring right now in political discourse. So if you look at debates or discussions with Charlie Kirk, and I'm signaling him out, or any of a host of people on the right, they repeatedly make assertions that are factually or RFK on health. They are repeatedly making assertions, and the core of their arguments are based on assertions that are verifiably false, but they are repeated over and over again, and they're framed in terms of this is common sense or this is logic or there are only two genders. That's things like that are not factually true. And yet they're repeat. So there is a very different basis for political discussion than there was 40 years ago in the US. And it's based primarily on misinformation, disinformation now, and not that the left is innocent of all of this, but it's much more pervasively, the distortions are at a factual level much more pervasive on one side than the other. So I'm probably getting too much into the politics here, but James Alexander mentions that past videos mention first line, second line, and third line ADHD medications. What is the typical sequence of meds you would try your average ADHD patient on? Like first Adderall, then Vyvanse, then Cymbalta, and so on. How did your patients who took modafinil or modafinil for ADHD end up on them? What is their request, or did you suggest it after they failed their first and second line meds? So for years, and part of it, and that's part of this is why I talk about, and I see my time's up. I have a video on ADHD induced, or not ADHD induced, amphetamine induced psychosis. I saw much higher rates of it in San Francisco in my practice than the reported statistics show. I think it's a really serious and worrisome side effect. So although right now in my practice, so a couple things. I have not taken any new patients since moving to Hawaii. Everyone I'm working with now, that means I've been working with at least 3 years. Some I've been working with more than 20 years. Um, I certainly, so the profile of where people are on now is different than what my starting profile. I almost always start with a non-stimulant before I start with a stimulant, just again because there are rare bad side effects with amphetamine that are not there with a non-stimulant. So it at least provides someone with peace of mind. I've tried something that's reasonable, whether it's bupropion, whether it's duloxetine, whether it's uh, before I tried something that's more dangerous, but also more likely to be effective. So in my practice, I more often, and Cymbalta was probably my most frequent starting point. If someone had had a bad response to some element of an SSRI, then I might be more likely to start with bupropion. There were certainly people who were adamant, I don't want to start with an antidepressant. I want to start with something that's FDA approved. I very rarely would start with Strattera, and my thoughts on that are in my video on Strattera. Um, and moderately often, again, because of the relative risks, people they'd have a trial of methylphenidate before a trial of Adderall. I often tried IR, immediately release Adderall before going to Vyvanse or a long range. For at least the last decade, Vyvanse far and away is the single most popular ADHD medication. So more Vyvanse than all other amphetamines put together. Vyvanse more than any um, methylphenidate product has been the single. So it works well for lots of people and not for everyone. So I don't know if that's enough of an outline, or I know you'll be back and follow up next time. So thanks for the good questions. And thanks for both returning questioners and new people today. So I'll be talking Friday at Medium Day, and we'll be back here next Tuesday, same time, same place. Stay healthy, stay happy, and try to gather information rather than misinformation.